Sir. Okay, Chaitra. Next
Shall I
talk.
start, ma'am?
Yeah. Chaitra is going to talk on wide field imaging for retinal diseases, clinical implications, and I think we are going to see more set of cases on how this Optos helps. But before you start, Chaitra, I just want to ask one thing. It has a 2D kind of a effect and not a 3D kind of a picture. So I'm sure there would be some limitations also. Maybe we can discuss after your talk.
Yes, ma'am. So, good evening, everybody. It's a pleasure to be part of this forum. I've been using Daytona Optos actually for many years. Initially, it came to us as a study unit, and we did a lot of research, even with Dr. Sada in the US. And then subsequently, we formed a study group called as IRA, and then we went on to do some more studies with 4 centers in the south. And it was so useful for us, both as a research tool and clinical tool. And even the patients really like the way we can describe their disease to them. That our center does have a instrument now of our own, and the amount of follow-up we've been having for the last 2 to 3 years, it's been an amazing tool for us to document these changes and prognosticate it for the patient. So I'll be speaking on wide field imaging for retinal diseases in particular, because the model that we have is the Daytona. I have no financial disclosures. With the Daytona, we are basically able to do more of the color images and the FAF, but I don't have the FFA and the ICG, which I'm sure Dr. Dogra will be able to tell us more about. So before we actually go into wide field imaging, let's look at some common things that we see in day-to-day practice, which a lot of anterior segment people would relate with. So this is your slit lamp with a 90 diopter lens. So this is how much we see, and most of our glaucoma colleagues will well understand what I'm talking about. Next would be our indirect ophthalmoscope. See, we just see about 30 degrees. So imagine when you have to look at 200 degrees, you actually have to steer the eye, you have to steer the patient, you have to steer yourself, the lens, and everything. And it's never visible at one view. And then you have your fundus camera. This is our regular fundus cameras that we use, which gives us about 45 degrees. And then you have to take multiple images and montage them together. Then we went on to 100-degree, some more fundus cameras, which gave us a little more view, where you see a little beyond the posterior pole and the arcades. But then came the optos, which is really ultra wide field imaging, and this gives us 200 degrees at one view. And like Dr. Debdulal mentioned, we can't see aura to aura, but you can see at least 80% of the retina. And once you steer the eye and you ask the patient to look up, down, you can actually manage to view the entire retina, if not in one single image. So what is wide field imaging? It basically describes imaging into the far periphery in a single capture. Now, why is it better than traditional retinal cameras, which offer a limited view, is that only 4 to 9 image montages are sometimes required to get that much of a view. And whereas wider field, cameras do not have this disadvantage where we have to take multiple images and then montage them, which itself comes with a lot of disadvantages. Montaging will cause some image distortion, will cause loss of some important information, and sometimes it just doesn't give us all the information that we need. Whereas this allows us to document over 80% of the retina in a single capture. So this is what I meant by montaging. If you can see, you have to actually manually do it. Some instruments do it on their own, also auto montaging, but it's just not the same. These are some of the other images of montaging. You can see that the uniformity of the image is lost. Sometimes the exposure may be different in each one of the captures, so we may not be able to see much. Therefore, we do prefer the optos, like 200 degrees in comparison to just about 15 degrees or 45 degrees of view, 15% of the retina is seen. It can help us get a lot more clinical information. And there are a lot of peer review literature now, over 800 of them, which have described just wide field imaging. You can detect, diagnose, monitor, and treat various retinal pathologies. And we've also been able to pick up a lot more sight-threatening pathologies in the far periphery, which may have gone amiss either during routine clinical examination or other imaging. So this is the device that we're using, and the Daytona in particular, just brief specifications about this device that we are using. Madam was mentioning that because this is 2D and also it's a curved structure retina, we may not be actually able to see it due to parallax. So there's also something called as ProView, which solves this problem. So this is initially how it helps us is to get accurate measurements across the image, even in the far periphery, and it enhances the image registration also for disease tracking. And intermodality image comparison is possible. Like I mentioned, you have a color picture, you have FAF, you have FFA, and ICG. So this particularly helps us also with that. So if you look at this, this is without ProView, and this is with ProView. It gives us a better perspective as well. So these are some other images that show how you can see it. So this is a good image where you can see the ultra-wide field and the extent of the 200-degree images. So some of the retinal diseases that we've been able to capture, I have divided it disease-wise and the common diseases and few uncommon ones as well. So DR, as we all know, is predominantly affecting the posterior pole, but of late, predominantly peripheral diabetic retinopathy has also come into the specialty, and we are seeing more and more peripheral lesions, which could be missed with just the ETDRS 7-field imaging. Price et al. Have also shown that with these wide field cameras, 90% increase in severity levels can be determined over the ETDRS grading. Now, going on to surgical retina itself, medical retina is important, but when we're planning surgery, if you see a picture like this, where you're seeing extensive, proliferative diabetic retinopathy extending far into the periphery, this is an extremely important tool for us to understand the disease ourselves and to also show our patients, to tell them how difficult it is going to be for us to manage. The prognosis also can be explained more. Now, this is a patient that I saw. It looks, very ominous when you see it at the first go. Here you can show the patient, now this is why your vision is so low. You have a huge, clot right in the center of your visual field, which is why your vision is poor. The rest of the retina may look very innocuous to him, but then you can explain, you can show the sclerosed vessels, you can show the proliferative diabetic retinopathy. Even despite treatment, there was progression of the disease, and the patient, progressively lost vision, and eventually, post-treatment, he's doing quite well. So we can document it serially. It's good for our own understanding of the disease and for the patient's understanding. So other retinal vascular diseases, especially, where more of retinal periphery involved, peripheral ischemia, neovascularization can be easily detected even if it's missed clinically. So this is a patient that walked into our clinic yesterday with, CRVO. It's so easy to explain to the patient, especially in comparison to the other normal eye. You can also see asteroid hyalosis in this patient. So you can tell them, you see the extent, it's going far up to the periphery. So obviously the ischemia is expected to be more. Eventually the patient would probably need laser treatment. As of now, intravitreal injections to manage the macular edema. This is a very interesting patient who came with, just 2 days post-delivery, who needed to be induced into labor because she had extremely high blood pressure. So, this is a very severe manifestation of preeclampsia, where you can see subretinal fluid, serious detachment, you can see choroidopathy, you can see a lot of these spots of choroidal involvement. I've just put in one picture. The other eye had the same manifestation. Especially for a person who's just delivered a baby, it's so important to deal with it sensitively. But the minute you show her, you explain to her what's going on, she and her husband were quite understanding of what's going on. And important is that these have medical legal implications, because the husband asked me one question: is this eye manifestation because of anesthesia? Is that why my wife has lost vision or decreased vision in both eyes? But here we could explain to them very well and documented it for future requirement, if any. Inflammatory diseases of the retina, extremely useful again because of the peripheral involvement. Now, this is a patient who had syphilis, and post follow-up, we kept seeing sclerosed vessels and a lot of vasculitis. And unfortunately, there was also a vascular proliferative tumor, which we picked up on follow-up, as you can see here. This is a patient again with vasculitis. You can see the peripheral involvement, good educative tool. Post-laser, you can see good resolution of the disease. This is a patient with serpiginous choroiditis. Again, extent of the disease can be well delineated here. Peripheral retinal degeneration, retinal detachment, as Madam was saying, it's very, very important, especially for patients undergoing, refractive surgery. You can document, you can show them, you can make them understand why we need to laser their retina before we actually take them up for refractive surgery. And, several lesions can be visualized at one go. It also helps us in surgical planning. Here is one patient who came with multiple tears. Some of them, this was actually PVD-induced post-inflammation. So rather unfortunate, but we got it on time, could laser the patient. Now, this is a patient with bullous retinal detachment, and we can show them why it has occurred. We can show these linear tears that the patient had, another horseshoe tear. They understand the requirement for surgery. This is post laser, again to document, and subsequently we could show that though one hole was treated, there were some more lesions that needed retreatment referred from another center. So again, to show them, this is important. Then AMD, we always think that AMD only presents in the posterior pole. Why would you need the, periphery to be seen? Why document it? Now, this is a patient who had a peripheral PCV that we all now are aware of, and post cryotherapy, you can see good regression of the disease. This is a patient whom, if you saw the posterior pole, would just think it's diabetic, retinopathy with macular edema. But then again had an, peripheral PCV-like lesion, which again underwent treatment, a middle-aged lady. This was a patient who actually, unfortunately, my animation is not working, a massive bleed in the posterior pole. This is on final follow-up today when I saw her, good resolution of her, hemorrhage, submacular hemorrhage. Blood dyscrasias, we see a lot of systemic issues, which we pick up actually in the retina department on the first go. Again, the severity and extent can be determined. This is a patient whom we saw first in our center, eventually investigated to found to have ITP, now on systemic management. This is a patient with anemic retinopathy or leukemic retinopathy, still under investigation. There were subbilumin bleeds. The other eye was already lost. So this eye was either a secondary or secondary to leukemia, and the other eye was lost. So we're still investigating this patient. This is a young intern, an MBBS student, who came in like this. She's just 23 years old, came in with this presentation, turned out to have a protein S or a protein C and deficiency, and now she's on treatment. Luckily, the other eye is fine. And if you notice here, I don't know if you can see my cursor, there was also a small arterial occlusion, arteriolar occlusion, which gave a scotoma. Now she's definitely getting better with treatment. Tumors, extent, severity. This is a young boy who's already lost one eye. He has VHL. You can see the number of angiomas. We literally counted about 12. Some of them previously treated. Now, unfortunately, he's developed a TRD, has undergone surgery, and brachy is doing quite well. This is his only eye. This is again patients with secondaries we are able to pick up. And again, like I mentioned, FAS is a good tool here to delineate. These are again, choroidal mets that we are able to pick up. This is again another patient where you can see, feeder vessel, very beautifully demonstrated for a VPT. Very useful in pediatric retinal diseases, especially because they do not cooperate. Those who have RETCAM, well and good, but even ultra-widefield imaging helps with children. And medical legal issues, sequential documentation, extremely useful. This is one of the earliest publications of optos in 2013 itself, where a flying baby position needs to be adopted and still can be done with rabbits. You can definitely do it with children. And here you can see these, congenital anomalies. This is an unusual case where we saw gyrate-like atrophy again in a young child. This is rather unfortunate. The father is a badminton coach, national coach. His child has this. We are unable to actually come to a diagnosis, but you can see the extensive, dysplasia in one eye. The other eye, fortunately, is good enough. This is again a dystrophy in a child, very young child. We could document in, both eyes. Came after visiting several centers. Some rare conditions, as you can see here, presented quite late. Looks like a dystrophy. We are still investigating the patient. And this is one most recent patient that I saw, unfortunately, an optic nerve avulsion. Vision is extremely low, but only one eye left. The other eye has auto-initiated. So it is, I'm not saying this just interesting cases. It has also helped us in diagnosis and follow-up. We have done a lot of studies. This was in 2018, again, with Dr. Sadda's group, where we could see automated now. We are trying to do automated, reading of these ultra-wide images so that it helps us in screening. These are these are some of our recent papers that we published in respective journal, where we could pick up peripheral retinal degenerations much better than clinical examination. So we did the sensitivity and specificity for these lesions. So to conclude, the results of several studies have shown that the results of ultra-widefield imaging does provide similar results to the ETDRS 7-field color photographs. It correlates very well clinically as well. Little experience is required actually for imaging, can be done by a photographer or by medical care personnel. There's a fast learning curve. It has promise for peripheral screening programs and telemedicine as well, because it's very quick and, it can be done, even in uncooperative patients. And to end, my thoughts would be the documentation and follow-up is excellent. It does help me a lot, like in this presentation and for my publication, patient education tool. The more said, the better. Non-dilating pupils, very easy. You can steer the eye and get better images. Non-cooperative patients as well. Pediatric patients, like I mentioned. Confirmation of retinal pathology in the periphery. And also minimal limitations are pseudocolor images that you get and cost. But then my patients are more than willing, to get an optos done because they want to see their retina. So many of them have never seen a retina before in their life. And when you say this is a picture of your retina, they're like, doctor, can I have a printout of it? So whether they're going to frame it or they're going to use it for a second opinion, I don't know, but they're definitely happy with getting their retina image. This is just to show what all you can see from the poster pole to the periphery. And it's definitely helpful for a learning person. I would like to acknowledge my team here and Dr. Rohit, who's helped me. He's my fellow in this presentation for the images. And definitely a wider perspective is always helpful. Thank you so much for this opportunity to AIOS and Optos team. Thank you.